Hello, my name is Dr. Kimberly Cheatham. Welcome to this presentation on Rh disease. The objectives for this presentation are listed here. Rh disease is a life-threatening condition that can occur when there is an incompatibility between the Rh status of the mother's blood and her fetus's blood. Other names for this condition are isoimmunization and erythroblastosis fetalis. Everybody has a blood type. Your blood type is one of four possibilities: A, B, AB, or O. What makes a blood type any of these four types are the proteins present or absent on the red blood cell surface. These proteins, referred to as antigens, are the A antigen and the B antigen. People with a blood type AB have both antigens on their red blood cells. People with O blood type have neither A nor B antigens present. In addition to the blood type antigens, there are Rh antigens. The Rh antigen is signified by the letter capital D. If the D antigen is present on a person's red blood cells, this person has a positive blood type. If the D antigen is absent on a person's red blood cells, this person has a negative blood type. Rh negative status is pretty common in the U.S. population. Approximately 15% of Caucasian people are Rh negative. The Rh or rhesus blood type system has several antigens: big C, big D, big E, and little e. A weak D, called Du, exists, which is treated as the presence of the D antigen. Other non-rhesus antigen groups exist as well. We'll focus on the D antigen. We care about the Rh status of patients because of the potential lethal effect that Rh disease can have on a fetus. If a pregnant woman is Rh negative, she does not carry the D antigen. Her body will see any presence of the D antigen as foreign and will attack it. It is common in a pregnancy for a little bit of the fetus's blood to reach the maternal system. If the pregnant woman is Rh negative and her fetus is Rh positive, the fetus's blood will be seen as foreign and will elicit an immune response in the mother. The initial response of the Rh negative mother to the fetal red blood cells is usually small enough to not affect the first fetus. The problem occurs with subsequent Rh positive fetuses. When the Rh negative woman becomes pregnant again, her body has already seen the D antigen and is ready to mount a large immune response against the second baby. Mom makes a lot of IgG antibody that crosses the placenta and attaches to the fetal red blood cells. The fetal red blood cells with the IgG attached are gathered up by the fetal spleen and destroyed. This leads to severe anemia of the fetus and possibly death. Here is an illustration of an intrauterine fetus. Note that the umbilical cord that carries fetal blood is attached to the placenta on the right. This is an up-close drawing of the placenta's attachment to the uterine wall. Fetal blood flows through chorionic villi that are in contact with maternal blood. Only one cell layer of chorionic villi tissue separates the fetal blood from the maternal blood, so they don't normally mix. When delivery occurs, or other trauma such as miscarriage, the placenta comes away from the wall of the uterus. Fetal blood vessels are damaged and fetal blood may escape the placenta and enter the maternal bloodstream. If the fetal blood cells are Rh positive and the mother is Rh negative, the mother's blood may recognize these cells as foreign. The mother will then mount an immune response by making antibodies against the D antigen. By the time the next pregnancy occurs, the mom has made plenty of IgG antibody against the D antigen. IgG antibody can cross the placenta. If the second baby has a Rh positive blood type, the IgG antibodies will cross the placenta and attack the fetal red blood cells, which leads to their destruction. Here is a drawing of the second fetus. Mom has antibody in her system ready to cross the placenta and attack the fetus's red blood cells that contain the D antigen. A fetus expresses the D antigen on its red blood cells by 30 days of life, so a miscarriage or early trauma can sensitize a previously unsensitized mom if enough fetal red blood cells enter her bloodstream. The newly sensitized mom initially makes IgM antibody followed by IgG antibody. In the next pregnancy with an Rh positive fetus, the mom's memory B lymphocytes are activated to produce antibody against the D antigen. What circumstances might allow transfer of fetal red blood cells to the mom that leads to her sensitization against the Rh antigen? Several possibilities are listed here. To establish a baseline in unsensitized women, and to detect any woman who is already sensitized to the D antigen, the standard is to check the maternal ABO and Rh status with an antibody screen on the first prenatal visit. If a woman presents with bleeding at any time during pregnancy or has a pregnancy loss, the blood type, Rh status, and antibody screen are also ordered at that time. There are two tests that can provide information about the presence of anti-D antibody. The first test is the direct Coombs. This test detects antibody that is already attached to an antigen. A direct Coombs would be run on a baby's blood after birth to see if anti-D antibody from the mother is attached to the baby's red blood cells. The second test is the indirect Coombs. This test detects antibody that is floating freely in the serum. An indirect Coombs would be ordered on the mom to see if she's making antibody to the Rh antigen. The antibody would be free in her serum, waiting to attack fetal red blood cells when it has the chance. Let's summarize why we care about Rh disease of the fetus. When the fetal red blood cells have maternal IgG antibodies attached, these red blood cells are taken up by the fetal spleen and destroyed. This leads to fetal anemia. If the fetus does not have enough red blood cells, then there's insufficient oxygen for the fetus to grow and live. The fetus can also become very swollen with edema. How can we tell if the fetus is anemic? One way is by serial ultrasounds to see if fetal edema is developing. We used to perform a special amniocentesis to draw fetal blood from the umbilical cord to test the hematocrit. You can imagine the risk associated with this. Today, we use Doppler ultrasound of the fetal middle cerebral artery in the brain. The velocity of the blood running through the middle cerebral artery can provide a clue to whether anemia is present. The fewer red blood cells present, the faster the blood flows through the artery. The only treatments available for a fetus who is suffering from Rh disease are in utero blood transfusion or early delivery. However, the earlier a baby is delivered, the less likely it will survive from complications of prematurity. Thus, it's a tricky decision. The key for Rh disease is prevention. To prevent the mom from ever producing an immune response against the D antigen, she can be given RhoGAM after delivery of an Rh-positive fetus, or after a miscarriage, bleeding in pregnancy, or after pregnancy-related procedures or trauma. RhoGAM is IgG antibody against the D antigen. The IgG supplied by RhoGAM attaches to any fetal red blood cells present in the maternal bloodstream and marks them for destruction before the mom has a chance of detecting the D antigen and creating her own immune response. Since RhoGAM has been administered to Rh-negative women in this fashion, the incidence of Rh disease has decreased dramatically. Giving mom the anti-D antibody is called passive immunization. The antibody lasts long enough to destroy fetal blood cells in the maternal bloodstream, and then it's gone. Mom never mounts her own immune response, and future Rh-positive fetuses are protected against Rh disease. One last important point. How do you know how much RhoGAM to give for the fetal blood present in mom's system? One dose of RhoGAM covers 30 ml of fetal blood, which is enough for most patients. If more than 30 ml of fetal blood is found in the maternal bloodstream, you'll need to give more than one dose of RhoGAM. A blood test named the Kleihauer-Betke can help. Mom's blood is drawn and sent to the lab where acid is applied to the blood sample. Fetal red blood cells are more resistant to acid than maternal red blood cells. The cytopathologist can determine approximately how many fetal red blood cells are present in mom's bloodstream by seeing how many cells are visible after acid elution. Thus, the Kleihauer-Betke can guide the clinician with how much RhoGAM to give. This concludes this video presentation on Rh disease.